Hello, everyone. I'm Kate O'Donnell. I use she, her pronouns. Welcome to our spring SBHC coordinators meeting. For folks who are new, this is our 3 times a year meeting that we hold to provide information and updates to coordinators, mental health providers, and SBHC partners about all things SBHC. As we are getting rolling with the meeting, we'd like to ask folks to write in the chat your name, your pronouns if you're comfortable, your role, and the SBHCs you represent in the chat. And then while folks are doing that, I am going to turn it over to Melanie.
Hi, everybody. Kwong, if you can go to the next slide, we are going to try something new as a way to kind of celebrate all the amazing things that are happening in your centers around the state, and just that we're coming to the end of the school year. And we're going to encourage all of you to share your school-based health center highlights with your collective community by using Jamboard. I'm going to put a link into the chat. I'll add it a couple times since there's a lot of things going into the chat. But basically, we'd love for you to add a sticky note or text that just shares something that's gone well for your school-based health center this year. That could be something like you made it through the year, or you were awarded a grant, or hired a staff member, or made a student smile that needed it. You got to take a lunch break. That could be a real highlight. Or you got to go to a conference or something. Like, I think there can be a wide variety of things to celebrate. And if you want to, you can also add your name or school-based health center or system to the sticky note if you want folks to know who to celebrate with. So for those of you that haven't used Jamboard before, you can see on the left-hand side of the slide, there's a screenshot of the toolbar that will show up on your Jamboard. I put a red circle around the sticky note button, but essentially if you click that little square button, it'll allow you to write text onto a sticky note, choose the color, and then you just hit OK, and it'll post, and you can kind of adjust the size. You can do more than one sticky note, and there's multiple pages that you can add to if for some reason they fill up, which I hope they do. And then we'll loop back around to this at the end of the meeting. So please add stuff that we can all hoorah about. Thanks, folks.
Thanks, Melanie. And it does look like people are already going in and adding sticky notes about what their successes are. I can tell this is going to fill my bucket today. So I'm really excited to see what you all have to put in the Jamboard. Okay, next slide, Kwong. So here is our agenda for the day. We're going to start as usual with updates from the state program office and some OHA partners. We'll have a quick break, and then at 2:10 we'll hear from our friends at La Clinica about Jewett SBHC. Then we'll hear at 2:30 from the Oregon School-Based Health Alliance. We have time at the end to share out some of the highlights that you all have been putting in this Jamboard, and then we will do about 10 minutes for Q&A and closing. Next slide. Just a couple of housekeeping items as usual before we get started. Please update your Zoom name so people who know who you are. As you saw, we have a pretty busy agenda, so please try to keep your questions and comments in the chat box as much as possible. We have Rebecca Jacobs, one of our public health nurses, has volunteered to kind of help read through any comments in the chat so everyone has access to the information. And then, as always, please take care of yourself during the meeting. It's a long meeting to be sitting. Please feel free to turn your camera off, get up, eat, move around, stretch as you need to. And a reminder that we are recording the meeting and we'll have it posted to our website in the coming weeks. Next slide. So first, updates from the School-Based Health Center State Program Office. Next slide. Here is our team. I think for folks who have been around, you should know all of us. The first slide is more of our program and administrative folks on here. Next slide. And then this slide, you will probably recognize our data and certification folks on here. Major staffing updates to share. Next slide. Okay. I'm going to lay on some funding updates for you all. This is kind of the boring stuff, but important to know. So next slide, please. So first, let's just talk about your funding for the current biennium. I think most of you know, but we are coming up on the end of our program budget cycle. And so a reminder for anyone who has not already, please spend down your funding for this biennium. So that includes your school-based health center base dollars, the mental health expansion grant funds. Most of this funding does not roll over beyond June 30th, 2023. If you did receive a COVID-19 American Rescue Plan Act grant, those do have a 1-year no-cost extension, but those must be spent by June 30th, 2024, if you did receive those funds. That's a little unusual. Those are federal dollars, which our program doesn't usually receive. That's why those are different. But all the other ones that most people get are state general fund dollars, and so those need to be spent by the end of the biennium. This year, we're also asking that if you are submitting invoices directly to us, if you have a direct contract with us, that you please submit your invoices no later than August 15th so that we can ensure that they are processed on time. And of course, if you have any questions about this or you have so much money, you don't know what to do with it, please reach out to us and we can help talk you through some options. Next slide, please. Okay, so now that we're wrapping up the current biennium, we're turning our attention to the upcoming biennium. So this is July 1, 2023 to June 30th, 2025. Essentially, we're looking at our base operating dollars, which is everybody gets $60,000 a year, and then our mental health expansion grants, the amount of which varies, and I'll talk a little bit more about that in a minute. Currently, as far as we know, our budget is stable. We don't anticipate any cuts, but we would let you know as soon as we know any more. The passage of Senate Bill 549 could impact our budget, that is, give us additional money. But our friends at the Oregon School-Based Health Alliance, stay tuned. I think they will share more about that later on in the meeting. We unfortunately will not know our budget until late June, early July, because it is determined by the state legislature, which is currently at a standstill. And so once the legislative session ends, that's when we know our budget, and that's where we can really start moving on this next biennium. Next slide, please. So just so you know where we're at with funding and our contracts and amendments, all of your awards for the next biennium have already been put forward. So if you get your money from local public health contracts, the fiscal year 24 amendment amounts have already been entered starting July 1. And if you have a contract with us, our contract administrator has already put forward those grant amendments for your contracts, your grant agreements. So hopefully in the coming weeks, if you have a contract, you'll hear from our grant administrator about that, and we'll be looking for signatures. Important to note, and I think Micah, who is unfortunately not here today, so I'm kind of going to do my best Micah impersonation and share with you this information. Micah did already send an email out about this, but just really want to reiterate so folks have the information. We did submit placeholder amounts for your mental health expansion grant awards. So what that means, essentially, we just put forward the same amount that you got last biennium as your grant award for the next biennium. This was just to make sure that the funding flowed continuously and that you had access to funds between biennia. We are still waiting on approval from the Conference of Local Health Officials on our proposed changes to the mental health expansion grant funding formula that Micah presented at our last coordinators meeting. We had sent a survey out to folks to get your feedback on it, and by and large, folks seemed good with it. But CLO did ask us to wait until we know our final budget before we present the changes to them for approval. So because we don't know what our budget will be until June, We have to wait to get that approval. And so that means once we get that approval, then we can make amendments to reflect your actual awards for the upcoming biennium. So when we get that approval, we will immediately move forward with amending the local public health contracts and the grant agreements. So the award that you initially get for mental health may be more or less depending on what that final award is. Next slide. Just a reminder, I know I said Micah presented this last meeting, but just so you're totally clear what we're talking about, this is the mental health expansion grant funding model that we are moving towards. It's based on the number of sites in your school-based health center system. And so that is the number of school-based health centers that are operated by the same medical sponsor within a given county. And so it's based, as you have more, you kind of get more money, but it's progressively less. It's essentially tiered. The goal with this funding proposal was to kind of minimize gaps in funding between folks, because we had a really wide range from like $40,000 for 2 years to like $250,000. So really trying to minimize the gaps in funding for folks and make it more predictable so folks knew what to expect. However, we do also know that if, for example, SB 549 does not pass and we do not get any additional money for our program, we will not have enough money to fully implement this funding formula in the upcoming biennium. So this is kind of what we're working towards, but we're trying to take some interim steps to get us there. Next slide. So if, and Maureen and folks from the Alliance will talk more about SB 549, if this bill does not pass, what we are planning to put forward as award amounts for 23-25 for mental health expansion grant is your award with bumpers based on your 2021-2023 grant award. So essentially you can't lose more than 10% or gain more than 10% from what your current award is in the 2021-2023 biennium. That also means that we do not have any new funding for sites that don't already receive mental health expansion grants. So we would need more funding from the legislature or another source to be able to fund new sites. Micah did send an email on April 12th. If you haven't seen it, it has all of this stepped out for folks, including individual awards by your site. So please reference that. We can also make sure to forward it if you have questions. Next slide. So I'm just going to pause. I feel like this is like a bit of a bureaucratic nightmare and like a lot of just like contingencies and things, and it's very confusing. And I think people are just like, please just tell me how much money I'm going to get because I want to fund my staff positions next year. So please feel free to write in the chat if you have a question, or you can also email me, the team, or Micah if you have questions. So I'll just pause really quickly here.
I do have a question, but I don't want to type it out. Is that okay?
Yeah, go for it.
Okay, awesome. I think all of the tiers make sense that it's contingent on the SB 549. My question is more specifically just about when we get closer to SB 549 and like sending those support letters to our legislators and senators and all the things. Could we possibly just get a reminder email with a slate so we could send it out to the staff that are interested on reaching out? Because I worry that with everything I have going on, I will miss it.
I will defer to Maureen. Okay, so maybe Maureen, she looks in like in the chat, Maureen said it's coming this week. So we at OHA are agnostic on legislation. We are not allowed to advocate, but the Alliance, the Oregon School-Based Health Alliance does. And so I think Maureen has slides around talking points and maybe reminders.
Awesome. Thank you so much.
Yeah, so stay tuned for that. Okay, well, I'm going to move us along. Like I said, if you have any questions about your individual site funding, please feel free to reach out. We're happy to talk. And again, I really apologize. I wish this process was a little bit easier and less bureaucratic. Okay, next slide, Kwong. Okay, I'm going to do certification updates and then give my voice a rest. Next slide. So speaking of bureaucracy, I think as people know, We are deep in the process of revising our school-based health center standards for certification. If you've been in these meetings for a while, you could see that this slide and this the process visual continues to change as we move through the process and things get added and we make little adjustments. So I just really want to, again, be transparent and let you folks know where we're at. So we've kind of moved through a phase where we did a health equity tool, we conducted background research, we convened an internal work group, and now we're starting to move outward in this process. And so I think, as you know, we held youth listening sessions and we sent out a link for a school-based health center survey recently. And then we will be spending the summer kind of doing some initial work to draft out a model and draft some initial standards for you all to provide feedback on. Next slide. So just a quick update on the youth listening session. So thank you to everybody who shared this opportunity within your networks. We really appreciate it. We wound up with around 20 participants total. I will say we learned a lot about internet recruiting. I think some of the information about the focus groups was shared over social media. We received like 700 responses of people who were interested. Many of them were not real people. And so it was a really good learning experience for us. Also in the youth listening sessions that we did, young people were pretty clear, like, hey, why don't you just like come to our health centers and talk to us? So lots of lessons learned, I think, about how we could be doing this differently in the future, but we have what we have for now. And so we have a small team at the state program office who are analyzing what we heard from the listening sessions, and we'll be writing up a report and sharing it back with you all to share what we heard. And then this information will be part of the kind of tapestry of information that we use to inform what we put forward as our draft first version of the revised standards. Next slide. I think you all also saw, and thank you to everybody who has already replied. I think we've heard back from at least 30 sites so far, or 30 systems. So this is a survey that went out, and really we want to provide as many different ways for folks to be engaged as possible in this process. And so we want to hear from you all about your thoughts on our current standards, the priority areas that we've kind of identified for revision, and then also about site visits. And so really, we just want to know what is working for you, what's not, how we can make things better. And so there's a link to the survey if you have not already responded or somebody from your system hasn't responded. And we'll be doing some follow-up next week if we haven't heard from someone in your system yet. But really, again, this information will be so helpful for us as we think about like what should we put into the new standards, what considerations, like where are folks already struggling with our standards, where could we make it better? And so this information is really essential. And again, this will not be the last survey that we'll send out. If you've been through this process before, we'll also be providing other opportunities for you all to weigh in on things as they come up. And then we'll send a survey and actually sorry, Kwong, could you go to the next slide? Here's some things that we'll be sending out. So we'll be actually reviewing and editing the standards in this upcoming school year, and then sending a survey for folks to provide feedback on those proposed changes. So keep an eye out. At the beginning of next school year, we'll be sending out a call for participants to participate in a standards review work group. That is a little bit of a time commitment, and totally understand that folks can't all participate, but we really want to ensure we have diverse representation from centers all around the state, representing rural sites, urban sites, FQHCs, non-FQHCs, behavioral health providers, really the gambit of folks. And so that will be coming in early fall. And I think the goal is to have like one meeting a month for folks to participate in. And again, if you can't participate in that, lots of other opportunities will be coming up to participate in different ways in the standards revision. And then, so next school year, once we kind of move through the edits to the standards, we're going to have to update our rules. And then we'll try and finalize those revised program standards. So lots more coming up. I think we're also moving to have an external partner advisory group, more information about that coming up too. So stay tuned. Next slide. Okay. Any questions about any of that before I hand it over to Sarah to talk data?
Okay, I just have a couple of slides about some data things. Yeah, thanks, Kwong. So I wanted to just give a little update on some conversations that our office has been having with OCHIN. I know that not everybody uses OCHIN, but enough of you do that we thought it was important to share with you all here. So about 3/4 of our centers are on OCHIN Epic. And a few weeks ago, we had a really great meeting with OCHIN that was sort of prompted by some questions we had related to our mobile and telehealth pilot sites that sort of blossomed into a bigger conversation. And so these were the 3 different areas that we talked about. We talked about being able to implement something to better get at the location of the student when mobile and telehealth visits are happening. We talked about electronic consents and integration into the EHR. And then we also talked about the ability to improve our data with respect to REAL-D and SOGI, which is sexual orientation and gender identity data. Next slide, please. So I have a few poll questions here. When we talked about the electronic consents, and we've subsequently had a few smaller conversations with a couple of our sites who are participating in the telehealth pilot. We've heard from some sites that this is a barrier in terms of being able to have an electronic consent. And different people are doing different things. Some people have this dialed in and really figured out. Some people know that there's an electronic consent option, but it's not working very well for them because it's not integrated. So I would just want to know, and Kwong, if you can go ahead and launch this question, whether you use an electronic consent form in your school-based health center.
Hey Sarah,
Yeah.
just a heads up that it's going to be all 3 questions at once.
Oh, okay.
Yeah, is that okay? Or
Yeah, let's go to the next slide.
okay, yeah, sorry.
No, that's okay. My fault. So we'll do all the poll questions at the end. So the other one of the other things we talked about was REAL-D and SOGI. The data that is part of our certification standards that's required on race and ethnicity has been in existence for a really long time. And it was developed before the REAL-D standards. And we also don't receive sexual orientation or gender identity. We get sort of sex, which is not even labeled necessarily as birth sex. But we know with Epic that there are these separate places for folks to be entering REAL-D and SOGI, and that a lot of sites are doing that. And so we are going to start getting that data. We do know that for the Epic sites, for the REAL-D data in particular, it's actually located on a separate tab. And so what we don't know is how many sites are actually using that separate tab, because essentially it would be entering that data in twice. And so we're going to start getting that data, hopefully. And this is not a new requirement. This is just if it's whatever's there, just to kind of increase the quality of the data that we're getting. But I am interested in knowing who is collecting this data, regardless of whether you're an OCHIN site or not. Who is collecting this data already, if you know? So go ahead to the next slide, please, Kwong. So there will be, I guess, 3 poll questions. So there'll be the electronic consent question. And then there will be these 2 questions about REAL-D and SOGI data. So REAL-D is the race, ethnicity, language, and disability data. And then SOGI is sexual orientation and gender identity data. And so I'm interested in knowing whether you collect this information, and is it through Epic or you're a non-Epic user? So before we launch the polls, maybe, are there any questions about the questions that I'm asking? Folks want to put them in the chat or just speak them out loud really quick.
So Sarah, this would be in the Epic, for example, it would be within the nurses charting visit, right?
Yeah, so it's there now.
It's-
It's just that we're not sure who's using it because it is a separate tab. So yeah.
Okay.
Okay. So Kwong, can you go ahead and launch the poll questions, please? So I'll give folks a couple minutes here to enter these. And then I just, as we continue to have these conversations with OCHIN, we will keep people informed. Just to be clear, at this point, this is nothing's really necessarily changing for you all. It's more just us trying to improve the quality of our data and also see whether there are any changes we can make that would help you all, thinking specifically about the electronic consents. So yeah, that would be really helpful. And I think, I'm not sure how many folks have answered, Kwong. Can you see that?
Yes, 30 out of 57.
30 out of 57. Okay.
So that's like 52%.
Okay, thanks. Okay, yeah, electronic consent would be a dream. I agree. I'm hopeful. I think OCHIN is they were very supportive. So I think, yeah, thanks, Maureen. I think we're hopeful that we can at least open the dialogue and see whether there's some improvements that we can make. Any questions about anything that I just shared?
Sarah, this is Jenny Stevenson from Deschutes County Behavioral Health. And I just wanted to let you guys know we are using the electronic consents. However, we are not using them for mental health visits for students between the ages of 14 and 17 because we have no way to verify that it was actually the student that signed that consent. Like a parent could go in if they had access to their MyChart and sign it for them.
Sure.
And so our legal team here at the county suggested we do only paper consents for that age group for behavioral health. I don't think that's the same on the medical side BHC visits. It's just with the county providers that we are having to do that. So it's just another barrier that it's really hard to ensure who is signing those consent forms in that online realm. So I just wanted you to be aware of how we're addressing that and what the barrier is. Yeah.
That's really helpful. Thanks, Jenny. And I might follow up with you afterwards if that's okay.
Absolutely.
Okay, perfect. Thank you. Okay. Can we go to the next slide?
Sorry, do you want to see the results or no? Just go ahead.
Yes.
Yeah, let's see the results. Sorry. Okay, so Got about half folks that do not use electronic consent. And then most people, or at least the majority, are collecting Real D and also Soji. So that's great. Yeah, that's really great. I mean, we know that this is, you know, as far as at the start of the pandemic, that there was requirements put in place as far as COVID data containing the Real D information, and we're really trying to move to that standard, but we want to make sure that it's available and possible for everybody to get there first. So thanks for that. Next slide, please. Great, thank you. So switching gears a little bit. So Kate talked about the listening sessions that we did for certification with youth, and some of you already know this, but this is my my ask for your assistance. We are doing some online focus groups with youth specific to telehealth. So trying to learn about how youth feel about receiving primary care using telehealth. We're going to be talking about things like privacy and confidentiality, you know, barriers with the quality of internet or technology, the importance of provider relationships and how those might feel differently in telehealth versus in office, that sort of thing. And this project is both in support of the telehealth pilot projects, and it's also part of my doctoral dissertation project. So I've started recruiting, thanks to those of you who have sent emails and posted flyers for me. I am in need of some more young people between 15 and 19, and we are giving youth a $50 Amazon gift card for participating. And this is not specific to school-based health centers. But I'm happy to have youth who are SBHC users, or if you have district partners who you think might be able to send this out to their youth, or community partners, that would also be wonderful. I'm particularly in need of youth in rural areas, although I need some more young people across the board. So I will be sending out a flyer that you can post if you want, as well as an email that you can share, and would really appreciate any assistance that you all are able to provide. This link that's here is just a link to the form, the recruitment form for youth, to indicate that they're interested in the study. So appreciate any help y'all can give me in this, and hopefully can use these findings and report out to really have a better understanding of how telehealth, you know, supports young folks in their primary care, as well as some barriers that we might need to explore a little bit more. And I think that is it for me.
Thanks, Sarah. I'm going to pass it over to Melanie to talk about training technical assistants.
Hi, everybody. Sorry I didn't properly introduce myself the first time I started talking, but I'm Melanie Potter. I use she, her pronouns, and I'm the school health program specialist for the unit. So we have some great opportunities coming up over the next school year. So I'm just going to go through a lot of our opportunities that we have that are kind of centered around some of our program requirements. So Loretta will be doing her annual operational profile training. You can see the date is posted there for August. So if you want to attend, mark your calendars. And that is for anybody who enters information into the operational profile. So feel free to share that invitation with the relevant folks in your centers. Karen and Rebecca will also be hosting another school-based health center coordinators orientation for new school-based health center coordinators and those that want a refresher. And that date will be in the fall of the next school year, and we'll send out more information about that particular date. Go ahead and next slide, Kwong. In addition, as predicted, we will be hosting more school-based health center coordinators meetings in the fall, winter, and spring. And then in the late spring of next year, just like Loretta did earlier this month, she'll be hosting another key performance measure audit webinar. And then one really fun thing that we're adding is that we'll have optional office hours with the certification team. It's kind of a hybrid to the check-ins that we did a couple fall, like last fall. Time flies, but essentially they'll be offering an open office hours every month for the school year, and so folks can hop on when they want to ask the certification team questions or hear what other people are asking, or just be in a space with your peers. And so that's open to any school-based health center folks with questions about the state program office requirements. Go ahead, next slide, Kwong. So we have more brewing. The last time we chatted, I mentioned that we were kind of looking into training and technical assistance opportunities for the next year. And so we've been planning additional optional training and TA opportunities that are kind of just additional supports kind of beyond anything related to our program requirements. And our office has we've chosen to really center what we're doing around our priority areas, which are youth engagement and health equity. Go ahead and next slide, Kwong. And so what these are basically just what we're thinking about. We are going to continue offering the open forums that we have offered a few of over this school year, and just for folks that may not have attended any or haven't been around long enough to hear me talk about them. Essentially, an open forum is a space for school-based health center staff to be in spaces with each other, ask each other questions, share information with each other, and support each other as well. And this next school year, we're going to be working on having a mix of preset topics for various staff groups, and also some open forums where we don't set a topic and attendees can choose what to talk about. So it's not preset, so to speak. So you'll see that we have the dates listed there for those opportunities. So mark your calendars, and of course we'll send out calendar appointments in the beginning of the school year. And then we've got a couple other opportunities that we're still working on developing and kind of determining on whether or not we're going to be able to offer them. One of them is a youth-led school-based health center assessment learning collaborative. So if we're able to offer it, the learning collaborative would essentially involve school-based health centers engaging youth at their schools to gather feedback about the clinic environment and provisions at the school-based health center. And then the school-based health centers would work on making a couple of priority changes based off of the feedback that they receive, or improvements, however you want to think about it. And so this, if we're able to do it, this will be a great opportunity for school-based health centers who've never been able to engage youth yet, or school-based health centers that really would like some feedback on their particular clinical environment. So stay tuned for more information on that. And then the other kind of bucket that we're looking at are working with more content experts to bring you all trainings on topics centered around health equity and youth engagement. And Kwong, if you want to go to the next slide. Also, I gave you a lot of dates, so here's a handy slide with a calendar that you can print off the PDF or take a screenshot so that it's all in one spot. All right, thanks, folks.
Thanks, Melanie. All right, I'm excited to welcome our colleague Emily Ellman from the Oregon Reproductive Health Program, who I think some of you know, and Emily's going to be giving updates on House Bill 2002. Emily, are you here?
I am. Can you hear me?
Ken, go ahead.
Hi, good afternoon, all. I recognize a lot of names today, so it's good to see you all virtually. For those who I don't know, my name is Emily Ellman. I use she, her pronouns, and I'm the Senior Policy Analyst with the Reproductive Health Program. We sit in the same section as Adolescent and School Health, and in fact, many of you are certified in our network of either RH Care or C Care clinics. So I was asked to talk a little bit about House Bill 2002. It's garnered a lot of media attention recently, and thought that it would be worth providing a high-level summary of what the bill includes, in addition to a couple of the provisions that I think are particularly relevant for you all. And I'm also going to kindly request that Wes Rivers or Sheila Johnson join me. They've been working very closely on this bill as well. And so if I've missed anything or misstated anything, I welcome their comments. So next slide, please. And I'm going to apologize in advance. The slides are a little bit text heavy, but I wanted you to have all of kind of the content available to you after this, just because it is a really large bill with a lot of provisions in it. So let's go to the next slide. A little bit of background about the origins of House Bill 2002, which is currently in the legislature. Last summer, and actually before the Supreme Court's ruling in Dobbs versus Jackson Women's Health Organization, which overturned Roe v. Wade, there was a leaked draft of the decision. And in response to that, the Speaker of the House, Dan Rayfield, formed a work group in sort of anticipation of the Dobbs ruling, and then afterwards, in response to the ruling, to identify opportunities to protect, strengthen, and expand equitable access to reproductive health care and other services under attack at the state and federal levels. And participants of the work group included kind of these partners. I was a part of this work group as well. And the ultimate sort of result of this work group that convened over the summer, again, in response to the overturn of Roe v. Wade, was to identify recommendations specifically for the legislature. They weren't all recommendations with a sort of a legislative connection. Some were kind of policy or administrative recommendations, but many of the recommendations were to drive legislative ideas for the legislature this session to introduce. So if you can go to the next slide, Kwong. Thank you. So the work group recommendations, as I said, resulted in a report, and you can actually click on the link in the slides to access the full report. And it included a huge body of recommendations that sort of touched on different topic areas, including provider networks, patient safety, gender affirming care. And you'll see that this bill includes some provisions related to gender affirming care. And these recommendations informed the drafting of House Bill 2002, which is called the Reproductive Health and Access to Care Bill. It's an omnibus bill, which kind of means it's loaded with all sorts of provisions related to reproductive health and gender affirming care. So go to the next slide, please. This is sort of a screenshot of the first page of the bill, and it's definitely been something that Democrats in the legislature have really touted as kind of landmark legislation to both protect and expand access to reproductive health, abortion services, and gender affirming care. And I'm going to now touch upon the various components of the bill. I'm going to start kind of with a very high level summary of some of the components that I think may be less specifically relevant to you all, and then we'll move into those that I think really will have the potential to touch the work that you do. Move to the next slide, please. One of the provisions in this bill is establishing a pilot project for 2 federally qualified health centers in rural and medically underserved areas of the state to expand reproductive health services and kind of more specifically medication abortion services. So with the anticipated impact of Dobbs and additional restrictions on abortion access in other states, there's a sense, and this has already been sort of borne out in experience, that the reproductive health network, especially the abortion provider network in Oregon, was going to be taxed with additional clients seeking services in Oregon from other states where abortion is banned. And some FQHCs have expressed interest in expanding their services, particularly around medication abortion, to meet this increased need. Abortion services within the FQHC model is really complicated because of the nature of federal funding that FQHCs receive. So the idea behind this pilot project is to give FQHCs participating support to figure out a model that will work and that will adhere to federal requirements with regards to separation of abortion services from the rest. And that pilot project will be operated or administered through the Office of Rural Health. Another provision in this bill, and it actually includes a number of provisions meant to strengthen protections for patients, providers, and facilities, both from malpractice, criminal and civil charges that many states, many more hostile states to abortion, are beginning to pass to really sort of come down hard both on people seeking abortion services, those providing or supporting people in getting abortion services. So this really sort of set of provisions is meant to protect patients, providers, and clinics. Can you move to the next slide? The next provision I want to spend a moment talking about is one specific to university student health centers. This part of the bill would require that all public universities and community colleges within the state to provide enrolled students with access to emergency contraception and medication abortion. And it would establish a grant fund administered by our program for student health centers to kind of plan and become ready to roll out these services. There are 7 university health centers, and I think Lane Community College is the only community college that we're aware of that actually has a health center on site. And the idea is, you know, I think most, if not all, already provide emergency contraception, but medication abortion would be a new expansion and would require support, and that's what these grant funds are intended for. I think this is particularly relevant for you all because there has been a lot of rhetoric and messaging, particularly among opponents of the bill, that are conflating this provision with school-based health centers and sort of messaging and mis and disinformation suggesting that this would require or encourage school-based health centers to provide medication abortion. And so just wanting, you know, that may be something that you've heard or may not be aware of, but just wanting to be, you know, clear that the bill is specific to university and community college health centers and doesn't reference school-based health centers, but there's been some confusion out there. Okay, now we're gonna move in. If you can go to the next slide, Kwong. Two more pieces very quickly. I'll start with the bottom one because that's very quick, which is just that it requires OHA and OHP specifically to cover a full month's, or excuse me, a full year's worth of contraceptives, so that providers can bill and receive reimbursement for a full year's worth dispensed. The gender affirming care piece is another provision that has been highly charged in the media. And I want to be really clear about what the bill is doing or does. It requires that commercial insurers, OHP, and CCOs to cover a full spectrum of gender affirming care services in accordance with accepted standards of care. So it essentially says that commercial insurers and OHP and CCOs may not deny medically necessary gender affirming care services. There has been quite a bit of discussion, both among legislators and other opponents of the bill, that are suggesting that this in some way changes medical standards of care around gender affirming care and or minor consent around gender affirming care. It does neither. It maintains current minor consent laws around medical services, and it doesn't change standards of practice at all related to gender affirming care.
Emily, sorry. I'm monitoring the chat and there's a question from Alex from Multnomah County. Just a clarification.
Yeah, so they're actually two, yeah, I see that. Thank you.
Okay.
Thanks, Rebecca. There are actually two different grant programs. There's one grant program specific to FQHCs that would fund as pilot projects 2 different FQHCs to expand to medication abortion. That is administered through the Office of Rural Health. And then there's another grant program specific to university health centers and community college health center to expand services to medication abortion. So 2 separate grant programs. So I hope that helps. Okay, great. Okay. And please feel free, I will leave some time at the end for questions, but if anything else you know, occurs to you, put it in the chat and we'll get there. Okay, Kwong, can you go to the next slide? Okay. So this is one of the provisions that I think is particularly relevant for you all, and it's specific to minor consent and disclosure. So as you all are aware of, minor consent for physical health services, medical services, is 15 and over. So minors under the age of 15 need parental or guardian consent. There's an exception for birth control and information services where there is no minimum age of consent. Minors may consent at any age for those services. This amends this provision and essentially expands birth control information and services to a much broader range of reproductive health services so that minors of any age may consent on their own to receiving a broad range of reproductive health services and importantly, abortion services. And this is another place where there's been quite a bit of conversation, both in the legislature and among advocates on both sides of the issue in terms of eliminating a minimum age of consent for abortion services. It also makes explicit that providers may not disclose information about these sets of services for minors without the minor's written consent. So it's pretty, okay, thanks, Kate. I will speed up. So let's go to the next slide, which is about public bodies. So this establishes that public bodies, officers, employees, or agents of a public body may not deprive an individual from exercising their reproductive rights, interfere or restrict in the regulation of benefits, facilities, services, or information, the choice of an individual from exercising their reproductive health rights, and public bodies may not prohibit a healthcare provider acting within the scope of their license from providing reproductive healthcare information and services to a consenting individual. And I think this is particularly relevant for you all as well, because school boards and districts are considered public bodies. And this has the potential to change kind of the nature of the relationship or control that a school district or school board may have on a medical sponsor or other providers' ability to provide a full range of reproductive health services, including dispensing contraception on site. So let's, I'm aware that we're out of time. So if you can go to the next slide. And actually, before we get to this, can you go to the next slide? Just really want to quickly kind of point your attention to the timeline. This bill has held multiple hearings and work sessions on the House side, the House chamber, and actually was passed out of the House on May 1st, at which point it went to the Senate side. And if you've been following the news, you'll know that the Senate, that the Republican senators, the majority of Republican senators, have walked out for the last 7 days to avoid a vote on this bill and others that they view as highly partisan. So it's unclear at this point when this bill will come up for a vote. There's lots of political machinations that are way beyond my area of expertise. In terms of, there is a law that that was passed as a ballot measure that says that legislators who have 10 or more unexcused absences are prevented from seeking re-election. And we will be getting for 4 of the senators to that 10th day this Friday. I think negotiations are happening today. So there's a little bit of a question mark related to the future of this bill, but Democrats have made it very clear that this is something that they ran on and aren't willing to compromise. So we will see. This Friday will be a pivotal moment. Let's see. Maureen, thank you. I see you have chimed in about how these conversations are playing out at the local level. Because we're short in time, and I'll wrap up, I'm gonna ask that if you have questions or thoughts about how any of these provisions might impact you all, if you have questions, if there are places where you feel like you might want or need support from the state program office, we would love for you to share that, because I think we want to ensure that if this bill passes, that we're providing you all with the support to kind of navigate what impacts this might have for you. So please, and then you can always follow up with me. I think the last slide, I have my email. Feel free to reach out to me directly or anyone on in the state program office, and they'll get the question to me. So thank you. Apologies for going over.
Thank you, Emily, and apologies to you for trying to squeeze like what is an incredibly complex topic into just 10 minutes. I feel like we could have spent clearly a lot more time on this, but it sounds like there's actually maybe more information to come. So stay tuned. We can definitely share what we know with folks as we know it. I am going to turn this over. We're going to completely switch gears now and talk about the survey that was sent out several months ago to folks. We have Taylor Chambers here, our colleague from the Injury and Violence Prevention Program at OHA. And Taylor, take it away.
Excellent. Well, welcome everyone. I will try to go through this as quickly as possible, but you do have access to these slides as well as my contact information. So if anything comes up after the fact, please feel free to reach out to me. So my name is Taylor Chambers and I serve as the Public Health Suicide Prevention Coordinator here at OHA. And what that means in short is that I oversee the state's Garrett Lee Smith grant. Next slide, please. So just a brief agenda, we'll review the goal of the survey, combine results from the survey, and the next steps if we have time for all that. Next slide. So what was the purpose of the survey? Well, the goal was to meet the Garrett Lee Smith grant objective that by June 29th, 2024, 100% of SBHCs will have implemented suicide risk assessment, referral, and or treatment protocols. And so this survey was a snapshot in time to see how we were doing. Next slide. First, thank you so much for completing the survey. The survey was released in October, and staff from 29 agencies representing 63 SBHCs completed the survey. So to note, in most of the results that we'll look at together from these answers, the sum will not total to 100%, and that's due to most questions allowing for multiple select options. So if you're hoping that things will equal 100% at the end of the day, they probably won't, and that's because multiple select options were available for most of the questions. And again, this survey took place back in October, and I think the last folks completed it in January, so several months ago at this point. Next slide, please. So the survey started by looking at staff trainings. 75% of those who responded reported that there is some form of basic training on identifying people at risk of suicide that has been offered to SBHC agency staff in the last 2 years. The most common of which was applied suicide intervention skills training, or ASSIST, at 44%, followed by counseling on access to lethal means, or CALM, and question, persuade, refer, or QPR, suicide triage at 31% each, respectively. The percentage of current agency SBHC staff who had received at least one basic training ranged from 0 to 100%, with an average of 50%. And then 61% of respondents indicated that some type of advanced training on providing suicide prevention and intervention services had been offered to SBHC agency staff in the previous 2 years. The most common of which was the Collaborative Assessment and Management of Suicidality, or CAMS, at 32%, followed closely by Dialectical Behavioral Therapy, or DBT, at 29%. Next slide, please. All respondents reported that their agency staff in the SBHC conducted at least one type of suicide prevention practice, with nearly all performing suicide risk screenings at 97%, and over 3/4 administer suicide risk assessments at 87%, and engage in safety planning at 83%. And we'll get into what each of these meant in more detail in their corresponding slides. So suicide screening refers to a procedure in which a standardized instrument or protocol is used to identify individuals who may be at risk for suicide. 29 of 30 respondents reported that their agency SBHC conducted suicide risk screening, with most offering screening in a language other than English in addition to English. And 2 respondents noted that their survey is available in any language due to on-demand translation services. 90% of respondents use the PHQ-9, or Patient Health Questionnaire 9, followed by 62% of respondents who use the Columbia Suicide Severity Rating Scale, or CSSRS. Next slide. And here's a look at how often folks are screening. As you can see, this data is a bit hard to interpret as it was a select all that apply, and more follow-up could be done to ascertain specifics. One agency noted that medical appointments are screened every visit with PHQ-9, CSSRS if positive PHQ-9, CSSRS and mental health assessments, and ongoing as identified in treatment. So I think more people could probably utilize, we would learn more from this if we had potentially just had one select option and then maybe an elaborate option as well. Next slide, please. Oh, I must have skipped a slide because I'm one slide behind you in my notes. So next slide as well. Okay, great. So in suicide risk assessment usually refers to a more comprehensive evaluation done by a clinician to confirm suspected suicide risk, estimate the immediate danger to the patient, and decide on a course of treatment. And this can involve structured questionnaires, but it can also be an open-ended conversation. So 87% of respondents reported that their agency SBHC conducted suicide risk assessments. In more than 3/4 of agency SBHCs, suicide risk assessments are prompted by a positive screen. And other assessment triggers include clinicians, ER visits, and hospitalizations. And a therapist or counselor performs suicide risk assessments in the vast majority of agency SBHCs. Others who typically do assessments include the nurse practitioners and doctors, among others. Next slide, please. So one respondent added that it's set up in our EHR system that feeds a dashboard for clinical compliance for screenings, safety plans, and treatment goals. Supervisors receive monthly dashboard reminders to review as part of clinician supervision or clinical supervision. Managers monitor overall team compliance. So that's just a look at how one SBHC does this work. Next slide, please. The CSSRS is the most commonly utilized formal assessment tool, with 65% of agency SBHCs using it. However, the amount of formal training on the tool was not asked in the survey. Like the screening tools, assessment tools are available in Spanish. About 54% have them available in Spanish, in addition to English. With suicide risk assessment usually comes a recommendation to do suicide safety planning. And a safety plan is a prioritized written list of coping strategies and sources of support individuals can use who have been assessed to be at high risk of suicide. And 25 of 30 respondents, or 83%, reported that their agency SBHC conducted suicide safety planning. About half use a custom or agency-specific safety plan tool, while others have it pre-programmed into their EHR, and some use the Stanley Brown, which is kind of the standard we see. In almost all responding agency SBHCs, a safety plan is prompted based on risk level through assessment, while a small majority completes a safety plan with all youth. And all agency SBHC staff develop safety plans for all youth with elevated suicide risk. And all safety planning in all SBHCs includes counseling on access to lethal means. And these were primarily available in English, with just over half had this available in Spanish. And again, a couple of participants had this available in all language through translation services. Next slide. 21 of 30 respondents reported that their agency SBHCs provided other types of support. And you can look at those on this screen and then the next screen as well. When a youth is at risk for suicide, all agency SBHCs can make referrals to a crisis or warm line. The vast majority of responding agency SBHCs can refer to the ER or psychiatric emergency service and or hospital. And then that goes down from there. Next slide, please. And like I said, the other types of support here is continued. Asking the question, when a youth is at risk of suicide, what referrals can your agency make? So the other types are listed there. And when transitioning to other health systems, most respondents' agency SBHC staff can provide youth at risk of suicide warm handoff referrals at about 86%, help scheduling appointments at 71%, follow up with parent or guardian at 67%, follow up at medical appointment if medical care stays within the agency at 62%, and follow up by phone or email within 48 hours to see how the youth is doing at 57%. One respondent's agency SBHC does nothing and considers a case to be closed once a transition is made. So by and large, that was not the majority of SBHCs we saw responses from. Next slide. Great. If a youth is hospitalized or has contact with the emergency department for suicide-related concerns, 72% of respondents reported that the hospital will connect with SBHC agency staff to inform them when the youth is discharged at least some of the time. So not always, but at least some of the time. And half of the 12 respondents whose agency SBHCs reliably received that contact had a policy in place to follow up with the youth within 48 hours of discharge. Next slide. And then if a youth has contact with crisis services for suicide-related concerns, 52% of respondents reported that their crisis services connect with the SBHC agency staff to inform them of contact at least some of the time. Next slide. As one respondent said, one thing we work very hard on is following up on any child seen in the hospital or emergency room for behavioral health and ensuring they are connected to services. We are also doing a handle with care program with the schools, police, as well as our agency. So that's how it looked at one agency. Next slide. 18 of 30 respondents, or about 60%, reported that their SBHCs conducted suicide risk notification. And that is if a youth is found to be at risk for suicide by an agency's SBHC staff. 89% of respondents noted that they will notify a parent or guardian. 72% noted they will contact a mental or behavioral health provider within the SBHC. And it goes down from there. All those numbers are listed on the slide. And I know I'm talking through numbers really fast. So just as a reminder, you do have access to these slides and can look at them in more detail, as well as the full report that you can look at in more detail. I want to note as well on the note of partnerships. Oh, next slide. Great. On the note of partnerships, in order to support suicide prevention and intervention at a school, school district, or county level, almost all responding agency SBHCs have partnerships with local school counselors at 80%, county mental health at 73%, and county crisis response at 70%. Of those whose mental health agency is different from their medical sponsor, about 1/4 reported that their protocols around suicide prevention and intervention are fully integrated, while 38% are somewhat integrated and 14% are not at all integrated. Next slide. The most frequently reported policies or practices that agencies have implemented to ensure that suicide screening, assessment, and treatment are culturally responsive to the communities that access services at their SBHCs are relationships within community-based organizations that focus on suicide prevention, intervention, or postvention at about 40%, and then youth engagement or education at about 37%. Next slide, please. So despite the good work that we're seeing, we know that more needs to be done. One respondent said, on the primary care side, we often feel ill-equipped to really deal with suicide. Next slide. So how can we help SBHCs? In order to meet the goal of implementing suicide risk screening, assessment, referral, and/or treatment and notification protocols by June 30th, 2024, respondents noted that their SBHC staff would need support around training, guidance on culturally responsive suicide prevention and intervention, and funding, as well as workflow support and customizable protocol templates. There were some other needs as well that you can note there, and as well as in the larger report. Next slide. So I want to share that we partnered with PSU to collect this data. Unfortunately, when we sent it out, we did not ask explicit permission to share identifiable or individual responses back to the GLS or SBHC programs within OHA. So some of you may have received an email from Kelly Hunter from PSU asking permission to share your individual response with OHA. And if you filled out the survey and did not get an email asking for consent, please reach out to Kelly directly. It is not required to consent to sharing responses with OHA, but it is extremely important if you do want that individual support. How we can support you is going to be a question mark without knowing who this data belongs to. So the staff from the state program office and the suicide prevention team have not yet determined what support will look like, but we'll know more once they have access to the data. So ideally, there will be continued statewide offerings for all SBHCs, but for sites to identify specific areas of support related to the Garrett Lee Smith grant goals, there may be more individualized support or smaller trainings related to that topic specifically. Ultimately, though, if anyone does not want to consent to share survey results, they can still reach out to either the public health nurse assigned to their SBHC or to the mental health specialist to ask for support. So you're welcome to reach out to Micah, who can direct you to me, or you can reach out to me directly. But the best way to share your data with us is to contact Kelly Hunter, and Kelly will share your responses with us. Next slide. And I don't really have time for questions today, so I'm going to go ahead and say next slide. Great. So thank you all so much. And again, apologies that I had to go through that really quickly. I'm going to just drop Kelly Hunter's information into the chat. So if you do need that, you have that available. And I'll put my own information in the chat as well if you want to copy and paste it and have additional follow-up questions for me. But you can also reach out to Kate or Micah directly, who have my information as well. Thanks so much, Kate.
Thank you, Taylor. Thanks so much for sharing such great information. It's really cool to see holistically what sites are doing across the state related to suicide. I think this is one of the first times we've really had an inventory like this. So as Taylor mentioned, we did send out the slides if people want to review them. There is also the full report, and we will make sure to send that also when we send the slides out after this. We did have time budgeted for a break, but I think we are over time enough that we'll probably I'm going to make an executive decision to just keep going forward. I just saw Melanie put a link to the Jamboard in the chat. So
Their car?
feel free to add to that Jamboard as you can during the meeting. Next slide, Kwong. Okay, so I'm going to turn it over to Rebecca and our folks from Jewett School-Based Health Center.
Hi, everybody. Rebecca Jacobs, public health nurse with the School-Based Health Center program. And super quick, we, as we go around and do our certification visits, we see amazing things, and we're hoping to spotlight you all in these meetings. So that's what we're doing here. And next slide. So we have from Jewett Elementary School, SBHC in Central Point, Oregon, David and Caroline, and I'm going to let you all introduce yourselves how you would like. So I know we're running a little over, so I think we're going to go ahead and get started.
Awesome. Sounds great.
Great. And Kwong, can you just, whatever you call it, stop sharing? Perfect. Thank you, so that we can see them. Thank you.
Thank you so much, Rebecca. Everybody, my name is Caroline. I'm one of the therapists at Jewett Elementary School this year. I work Tuesdays and Thursdays. I'm bilingual, so I primarily work with the Spanish-speaking population, which is growing faster and faster at Jewett, which is super exciting. We are going to have a really tight conversation today with not a lot of density, we're hoping, because David and I are really hoping to highlight some of the amazing interventions we've been able to utilize with a focus on how do administrators support room for amazing interventions like this. So when David's ready, he's going to jump right on in with a few minutes of context and his own introduction. And also, since we did have to skip the break, anyone who needs to get up and stretch, we know you're doing what you need to do. Just listen in the way you best can.
Hey everybody, thanks Caroline. I'm David Smith. I'm one of the other therapists at Jewett. I've been here about this is my third school year. And I was the only full-time therapist, the only therapist here for a while. Caroline joined us this year, which has been awesome, in part because she can add a Spanish-speaking component to our services. Jewett is one of 19 sites that La Clinica covers. Schools from elementary through middle and high school, as well as a couple of magnet schools and other sort of specialized locations. Jewett is an elementary school that has, depending on the day, between 600 and 630 students. It's one of the biggest in our valley, and it was built, as you could probably see from that picture, it was built a long time ago for a population about half that size. So the school is older than I am, which is saying something. We cover kindergarten through 5th grade. We have one of the few two-way immersion Spanish-English programs in the area. So it attracts a large number of families that are Spanish-speaking at home or who are English-speaking but want their children to be raised in a bilingual environment. So roughly 30 to 35% of our population is primarily Spanish-speaking. We're located in Central Point, down in the Rogue Valley. For those who have not been here, it's a working class community, fairly low income, fairly high trauma. The Rogue Valley is somewhat isolated from the rest of Oregon. It's a pretty vibrant area in its own right, but we're a long way from pretty much anywhere else. So from here to Portland is about 3.5 to 4 hours, depending on how fast you drive. We at the school-based health center, we're a full-service clinic. So we have, I'm one full-time therapist. We have Caroline here 2 days a week. We borrow another therapist from one of our less busy schools another day a week, and then we have a therapist intern. We also have a provider who's here 2 days a week. We have a nurse 5 days a week. We have a community resource specialist who's here, covers roughly 10 or 11 schools, and is here every now and then to help connect families with resources. And we have a what we call a patient service representative who kind of holds the whole thing together and schedules everybody and talks to families. We provide services in both English and Spanish, and have translators available whenever possible. So it's kind of a big program. And I know some of you in other SBHCs around the state are not as well resourced as we are. Some of you work in some pretty isolated environments. We're very lucky in some ways to have the kind of resources we do. And we have a very, very busy school. So when I started here, September 2020, it was actually the actual day that a wildfire spread through the community and destroyed 2 neighboring towns. It was also the middle of COVID. That year, I think I was one of maybe a dozen or so therapists in the community who was still seeing children and families in person. They gave us the option. So our school was kind of a ghost with teachers here, but no students for quite a while. And then students and families were coming in to see me for a bit. It was a weird year. We saw, I think my caseload that year maxed out at about 17. The year we came back to school, it went up quite a bit. And so last year was our first full normal year back. We saw 98 students. So remember, it's a school of about 600 to 630, so 1 in 6.
Yeah, which
That was
feels
a
like a
big
lot.
spike. It was a big spike that year. This year, for reasons that we're still kind of debating, it's been much faster. It's been much more acute. We have gotten officially 115 referrals as of yesterday. And there are another 45 to 60 that we have kind of sidetracked into other settings, which Caroline will give you more information about.
In 1 minute.
We've just been kind of swamped. So we've had to innovate a lot. And our population has a lot of trauma and a lot of, for various reasons, we've got a lot of kids who are neurodivergent, autism, ADHD, Tourette's disorder. And the acuity rate of the referrals that we've been seeing this year has been higher than they've been in the past. So I don't know about a lot of the rest of you, but we've been seeing a lot of issues that would normally come up in middle and high school showing up in 3rd to 5th grade. And we've seen a lot of 3rd to 5th graders acting more like kindergartners. So it's been this really interesting kind of environment. So we've had to do a lot of innovation to do more and cover a lot more need without increasing our staff, because we just don't have the people available to bring in, even if that was the best option. So Caroline, you want to talk a little bit about some of the things that we've done?
Absolutely. Thank you for the context, David. So with that background in mind, I want you to remember the main question we're thinking about in this conversation today is how do administrators and leaders help create a culture where their school-based therapists, their school-based programs are going to be able to flexibly meet the needs of a school while decreasing burnout. Okay, that's the dream. That's what we're thinking. That's what's on our minds. So now that you know a bit about the context of our school, I think that you should know that David has built a really strong relationship with school staff. However, in our small community here in Central Point, there is a very strong political divide, and that political divide plays out on campus among staff as well. Half of staff are feeling like they're wanting to be more engaged in the social emotional learning and wellness and well-being and to really dig into these topics. And the other half of the staff are feeling very strongly that it is not appropriate for anyone beyond blood family members to be a part of this process. And so not only do we have to support students, but we have to also see the school as our client. And so David and I have worked really hard to help all the varieties of political leanings at our school focus on the goal, which is wellness. That instead of allowing political conversations about what should or shouldn't be happening here or there at what age, we always work really hard, despite our own personal beliefs, to see the school as a client. And when your client has beliefs different than yours, you stick to the treatment plan, you focus on the goals. And so that's what we've been doing with our school. Now, how do you do that concretely? Well, David and I are very different people with very different backgrounds. And so we also have very different skill sets, and we use that to sort of divide up which staff are going to work with which of us more easily. He spends a lot more time chatting up the principal. I spend a lot of time in the office of the assistant principal. Now, we never specifically sat down and drew this out, but we knew, hey, if we're going to build a relationship, let's lean on our existing identity characteristics that we have in common with other staff. Let's get them to trust therapists as a whole because they trust us. And then maybe they'll trust mental health processes. Maybe then they'll trust a bit more of our wellness initiatives. And that's going to come up at a lot of different campuses in Oregon. There's a lot of amazing ideas, but there's also a lot of conflicting politics to consider. So how do we concretely get the school on board? My thing is always this: teachers are already doing too much, and they deserve to be paid 10 times more. So I am never, and we are never, trying to ask more than we are giving. So when we are entering into any conversation, I always start it with, what I'm giving you is, could you help me buy? And so that seems like a really abstract concept, but it sometimes is as concrete as this. I want to run a group to support a bunch of the students who are really struggling with dating relationships on campus, because I heard there's been some lunch drama. So I'm already giving the gift. And then I say, I need some school staff to participate so that facilitation will be easier in a group of this size. Who would you recommend so that we can solve this together? So instead of saying you need to send teachers to deal with the drama that's coming up in the therapy clinic, I'm instead starting with, what am I offering you? And how can we partner? I think we think a lot about the abstractness of being partners with our schools, but the truth is we have to get really concrete. I don't think that David and myself can solve all the emotional needs of our campus. However, if every time an emotional need comes up that is within our scope of practice, we find the appropriate school staff to join that intervention, then we can diffuse our expertise across the entire campus. So for example, we have a skills trainer who is a bachelor's level support person with excellent expertise in mental health. And so she does a lot of the groups related to students managing ADHD symptoms, which is within her scope of practice. However, we also know she's not infinite. So we went to the school and said, hey, we want to offer this group, and all you need to do is offer one staff member who in their contract has time for this. And they picked someone. And now whenever our skills trainer is out sick, the group could go on without her. And even more importantly, we're empowering the existing school staff to realize, wow, we can solve a lot more of these tier 2 level emotional needs ourselves, save the clinical referrals for stuff that cannot be treated without ongoing individual therapy from a licensed or soon to be licensed clinician. That kind of partnering and buddying requires a lot of consistency. So we're a big fan of note-taking and following up so that they constantly know that we are keeping in the loop with this. We are not just pushing needs onto the school campus, but we're building more partnership. One of the ways to do that is to really focus on getting time in the school schedules, which, if any of you know, based on this meeting, time is so precious. It's so hard to get time from very busy individuals. So we always start really small. David did a wonderful job in the last couple of years, squeaking 5, 10, 15-minute meetings into the training week with teachers. Now, what we can do now that they've seen that 15 minutes was worth it is we can get ahead of the game. So in January, I started talking to the assistant principal about the school planning schedule for the next year. Because if you don't talk about it in January, you won't be on it. So every week I either sent an email or walked by and said, hey, just reminding you when you're making the schedule for the training, we'd love to be on it. We'll discuss the topics that you think are important. Again, this is a gift for you. You tell me what topics you want your teachers to better understand, and we'll add our expertise. That's the best way for us to make sure that we get to share the La Clinica information, but it also feels super meaningful to school staff. So now, because of all of those ongoing conversations, because of all the gifting of interventions, they're giving us 30, 40 minutes a couple times in 1 week, which is amazing and incredible, and we're so grateful. Now, how does this become something that isn't just Caroline and David's unique style that's working for them at their school? How does this become a way that all school-based health centers can better approach the work? Behind the scenes, David and I have worked really closely with Elise, who is our director, talking a lot about what is the bottom line that we have to do as La Clinica therapists to ensure the longevity of our position at this school. Because a lot of what I've described is not billable. And as we all know, I have to get enough billable minutes to pay for my position to be here. Now, for new therapists who are just up to their eyeballs in learning, it's maybe not the time to get super flexible about creating groups and trying all these new things, which is why it's great to have brand new people paired with folks who are more veteran, which is something that we do here very well. But as your therapists start to grow and want more of that freedom and flexibility, find ways to be really honest about the bottom line. You know, if your bottom line is, you know, we say we need you to have X clients, but we only do that because you really need Y minutes of billing. And if you are interested in getting Y minutes with a different number of clients, as long as you get the minutes, I, as your administrator, am willing to work with that. Finding ways that you can get to that bottom line will really work. And that's what we were able to do with Elise. I said, look, this school has 150 students they want in therapy, and there's 1.5 of us. It's not going to happen. But I think we can serve all these needs if we can do some of it non-billable. What are your thoughts? And we were able to be really clear. I didn't serve all of them, but I did 2 hours of non-billable groups, and that saved a bunch of heartache for our school campus. Now, that being said, it's not easy, it's not simple. If we had an easy, simple way to do it, we'd have made you a PDF and just emailed it. But we really wanted to share what's been going on our campus, how we've utilized groups, how we've utilized buddying with school staff in order to have more longevity, and how we've gotten really creative about balancing the non-billable and billable time more directly. It happens already. They're already doing non-billable stuff, but to directly discuss how much and when can be really helpful. We're going to dive into the next 4 minutes with just a minute or two each of what does this actually look like in our day-to-day. And then if you have thoughts or questions, please throw them in the chat so that we can respond to them. But David, do you want to start with a minute or two about your day-to-day?
Yeah, thanks, Caroline. I was very lucky to have a good supervisor in my first internship, also school-based, who told me early on that 5 minutes with a teacher or a parent could in the long run make a far greater difference than any number of weekly sessions one-on-one with a second grader. So often, especially when there's a cluster of things going on in a particular classroom, I'll do push-ins. So I've been doing sessions with the 5th grade classes often about what's inappropriate to be talking about with friends in class, because there's been a lot of crazy behavior going on. I'll go check in with teachers where I've got a pocket of kids that they work with, because helping them learn how to better regulate those kids doesn't just help my clients, it helps everyone around them. I'll be doing on a typical day anywhere between 4 to 6 individual sessions, which for me is usually about 30 minutes. A typical elementary kid doesn't regulate for a full 50 or 60-minute therapy session very successfully. So they tend to be fairly short. I'll do a lot of parent calls. I find that family therapy is really effective, especially at working with elementary age kids, to the point where I try not to work with families and clients where the parent is not willing to be involved, at least to some degree, because these kids cannot out-regulate the environment that they're living in. So family therapy is a very large part of my work. Working with teachers directly, once a month or so, I'll go in and check in with them and see how kids are doing and suggest some things they can try. We attend they call them SST meetings here. I don't know if that's true throughout the state, but I attend those as much as I can. IEP meetings, 504s, do a lot of referral follow-ups. Sometimes even just giving a parent a few suggestions can be the first step in triage. Try this and see what happens. And if things don't get better, we'll follow up in a couple of weeks, and then we'll see if we can get you in for therapy. And then, there's a lot of interactions with the PBIS here, because that's where a lot of these kids wind up one way or the other. So trying to help the people that are supporting these kids on a day-to-day basis figure out how to manage whole clusters of groups and behaviors There's a lot of education involved for the whole school staff, and consultation with the rest of our team.
Yeah, we're using consultation as another way to spread out our expertise without overburdening ourselves. At our campus, we have no limit on the number of superheroes who are ready to jump in and burn themselves to the ground to help the kids. And that's not sustainable. And it creates a culture of urgency that is not appropriately correlated to safety concerns. And so a lot of what I've been able to do as someone who came from a school that had a lot of safety concerns, more than Jewett safety concerns, is to really help the staff to slow down, triage, prioritize. And so rather than seeing every 150 students who are referred as equally needing a therapist, really understanding there's only going to be so many. So my day in the life, I probably see far fewer individual clients than you might expect, because I spend so much time with teachers. However, I'm able to creatively bill for environmental interventions. I'm able to creatively bill for the collateral conversations, for the communications with the parents. And so while my minutes of individual therapy are lower, I think they more appropriately are meeting the needs of our clients and the needs of our school, and better aligning with the ethics of what it means to provide therapy to a child outside of their environment. Asking a child who's 7 to do new things to fix ADHD is absurd. Of course, we wouldn't do that. So what do we need to work on to support their efforts to achieve clinical goals? Their environments. Ideally, that's going to be the family. They're coming in, they're connected, they're trying new things. That's not the kind of family who has time for me. So we often are working with the school as the second main ecological space that the students interacting with. So my daily life is, in every 5 minutes, I am touching base with a random teacher in the hallway and then following back up with a billable conversation about interventions. Instead of just chit-chatting, I'm saying, hey, how is this goal being approached with this student? Would you like additional ways to work on this? When can I push into your classroom to do it? Let's set a time. I'm pushing into classes so that instead of waiting for clients to struggle enough to get on the referral list, I say, hey, if your whole class is really struggling with focused attention, let's just give you 30 minutes of my unbillable time, and that'll keep 5 kids from being referred next month, because their teacher and their classmates will all have a little bit more skills in how to maintain a safe and calm demeanor. This again is only possible by being really direct and clear with administrators about, what is the bottom line? I learned early on, there's what's legal, there's what's ethical, there's what's policy, and there's what you do. And all of them have to align, but giving them all equal weight is not accurate. Some things have to be an absolute no, and other things I would recommend, you take some time to consider. Where are the spaces for flexibility that will allow our clinicians to, 1, better meet the needs of their schools flexibly, and 2, feel less pressure to burn themselves out with infinite individual clients when another model might work and may also be able to pay for itself. Does anyone have any additional questions as we wrap up our conversation?
No, we are running late, but I do want to pause. I just really appreciate the information that you shared and just want to give people space to ask any questions that they might have.
I also dropped my email in there so that if folks want to touch base and find time, collaborating is the name of the game. So we're very into having any conversations that are going to support other students wherever they might be.
As we're waiting to see if any questions come in, just wanted to thank both of you again. I just really appreciate you recognizing the reality of burnout and thinking about creative solutions. It's something I think we hear again and again about the level of stress that folks are under and the urgency. And it's really inspiring to hear about how you've been trying different ways to meet people's needs. So
yeah, that burnout is real. And I encourage everyone to remember that you are not a fungible resource. We do not have a pipeline to replace you guys. So self-care is super important. Taking care of your team, taking care of each other, and some of you are administrators. I assume some of you are also therapists. There's a nationwide shortage of mental health professionals in general, those who are willing to work with children in particular, those who are willing to work in schools in this crazy chaotic environment that is ever changing and you never know what you're going to get every day. That's a tiny sliver of a very small pie. So
Absolutely.
work on whatever you need to do to prevent burnout. And some of that is just basically caseload management. We can talk about self-care all day long.
Yeah.
But that's a Band-Aid on an amputation at this point.
Yeah. The truest self-care is my boss saying, you are doing enough. You don't need to do more. Because then I know, okay, there's more to be done, but my boss is good. So now I get to choose. Some days I'm going to do some more because look at me. This is the energy I have. Some days I am not going to do more, and that's good too. I'll also name I'm part-time because I have children and I can't have this energy every day anymore. And so that also the flexibility an administrator gave me to be part-time empowers me to be far more efficient than I ever was full-time. I left my previous school because they could not accommodate part-time options. And as a licensed bilingual therapist, I was like, I can do better and you know it. So you need to think about that. As you're worried about losing staff, maybe you don't allow a part-time, take the summer, talk it through with HR and with your directors, because it is the future of keeping good therapists in schools, is allowing for more flexibility. I also saw another great question. Folks are talking about how to manage privacy issues when it comes to school and school district rules. That's where it starts with the administrators understanding the contracts. So mine was able to say, we don't have a contract with the school. Our contract looks like this, XYZ. I've worked other places where there was a very specific contract with the school about exactly what we could and couldn't do. Being open about that with your frontline therapist is going to help them contextualize why they can or can't do some of those options. I will also say that building trust with the school is going to allow them to open up. So you could perhaps start that campaign right now so that maybe by next school year or the year after, they start to recognize the value of allowing you in other spaces. I'm always really clear and say, I will be in the back of classrooms. If I approach the teacher, it means I need your assistance. If I'm in the back, I'm observing. Administrators have been fine with that. But I also tell that to clients so that they know me being somewhere doesn't mean that there's a mental health client nearby. And so they get used to it. And one of the greatest tips I got, and that I would recommend you give to your therapist, is don't be in your office, be in recess, be on the yard, be in the cafeteria, so that students get used to seeing them in non-therapy moments and stop associating the stigma of, oh, this must be a HIPAA issue if you're out here. Like, I'm everywhere. So they have no idea who I'm working with.
Yeah, and on a practical note, I've got 1 minute before I have to leave. Just to Jennifer's question, we have a release of information with every single client we work with to communicate with the school. So we are covered in terms of having communications about our clients as long as it is under HIPAA regulations. We also sign, I forget exactly what it's called, but there's an educational need form that the school district sends to us to sign that we have a legitimate educational interest to be interacting with school personnel. So those are part of our standard procedures that we follow with every single client, with every single one of our staff members. So the basics are taken care of.
Yeah.
The school staff can communicate anything to us that is consistent with FERPA. Okay.
Yeah.
Their rules are looser. We can communicate with them anything that's consistent with HIPAA because we have that release of information with every client. If a parent is not willing to sign that release of information for us to communicate with the school, our ability to do anything for them is very, very limited, right?
Yeah.
So that's just part of our standard operating procedure.
When thinking about smaller schools too, and the HIPAA concerns related to the non-clients, I definitely think that's where it's going to be a longer process, but advocacy with the district around what it can mean to have classroom-wide push-in support. That is a gift you can give to the school and the district and say, hey, I notice your teachers are like overwhelmed, they're overburdened, they're underpaid. We can't fix that, but we could, if you were open to it, we could lead class-wide. We're not singling anyone out. No one needs a consent, but we could lead class-wide activities on being calm or whatever is the chillest way to approach mental health from the beginning, which usually is being calm and safe at school. And see, if you can, with advocacy, get approval from the district to say, you know what, as long as it's school-wide and it's not targeting anyone, I guess it's okay. That would be, stage one of how to kind of get in. And then the only way that you're going to get the freedom to be flexible is by building trust, which is a long process, which is why when David and I started doing a lot of tier 2 groups, we ran like 10, 12 different groups we supported. We only ran 2 of them because we started at the beginning of the year saying, if you want to have groups, we will plan it, we will make it happen, but you have to run it. They saw it worked, and now they're going to run twice as many next year. So it's about showing up and offering a gift. What can I gift to you so that you'll open the door to me?
Thank you, everybody. I'm
This
gonna have
is
to take
awesome.
off.
Thank you so much. I've been texting with some staff and feel like this could be an open forum topic. So maybe stay tuned. I feel like there's lots of conversation. We really appreciate you being here. Thank you.
Yeah, please do email us anytime, and I'll let you continue with the rest of our meeting. It was wonderful to meet you all.
Thank you so much. Okay, I think our last presenter is Maureen from the Oregon School-Based Health Alliance. I know you all have been waiting for the SB 549 updates. Kwong, could you bring up the slides? Thank you. Next slide. There you go. All right, Maureen, it's all you.
All right. Great. Thank you. So I'm Maureen Hindon, the Executive Director of the Oregon School-Based Health Alliance. And go to the next slide, please. So we have been working on SB 549. As you heard, it's gonna bring more money if it passes. That's the gist of it. Next slide. This describes exactly what is being asked for. The biggest things are like an inflationary increase for school-based health centers, and then an increase in the school-based mental health funding, and capital construction, and then more planning grants. Biggest things as far as what will impact you all directly. Next slide, please. This is kind of a little guide. We actually made it for youth, and then I was like, I think this would actually help adults too. As far as thinking about how to write your testimony. And on the previous slide, by the way, when you get them, there's a link for where to find the people to whom to submit your testimony. So right now, the bill is in Ways and Means, the Ways and Means Education Subcommittee, which means Ways and Means are the people that decide where the money goes, how to allocate it. And as you can imagine, there's a lot of competition. Everybody's like, yeah, this is a good bill, but our budget, it's tight. So the more voices they can hear, the better, of course. And so we would love folks to contact the Education Subcommittee. And we just made an agreement with the Oregon Education Association, and they're going to actually loan us their communications people and their advocacy tool, which is really awesome because you probably have all gotten these in your personal emails. It's like send a letter to your legislator and you click on a button and it will do it. But I want to emphasize this piece here that's on the screen, which is, yes, there will be kind of a template for you, but actually providing your experience means that they're more likely to read and digest it than them getting a whole bunch of generic emails. So we will be making it easier. You're also welcome to call or just email them directly. That is probably more effective, to be honest, but this other way will also allow like your average citizen to also be able to advocate without really knowing that much about how the system works. And I want to, I don't have this in the slides, but while I'm thinking about it, we also will be doing advocacy in DC at the national conference. So if anyone's planning to go to the national conference, we have a room set aside for Oregon folks. We will have a gathering. We can, network and chat And we will also kind of be pulling together like who wants to go up on the Hill and advocate. So that will be happening as well. Next slide, please. You probably have gotten emails about this and you may have attended the webinar, but if not, I just wanted to let you know that we do have this SBHC marketing toolkit available for you. It's specifically designed. There are 6 or 7 languages, I'm forgetting how many, but multiple languages, the flyers, the posters, things to put in your newsletters, stuff for website. A couple of sites have been able to pilot radio ads, and so there are some scripts there. There are plain graphics, and all of this is, you can see it's like font that you will have, so you can change it, you can print it on a regular printer, you can make it fancy if you want. But we also have stickers and magnets available. So if y'all want some, we can send them to you to put out in your centers. And the link to the toolkit is on this slide. So you will have that available. Next slide. We are looking at our membership structure and fees and really wanting some SBHC input. So I know we have a few people that volunteered, which I'm very excited about. But if other folks would like to participate in giving us some input about what kind of membership benefits we could provide, and what kind of membership rate structure would be most doable for you, then please contact Hannah at the email that's on the screen. It's about 3 one-hour meetings. We're not going to try to all cram them into June or something crazy like that where you don't have time. We'll try to make it be a reasonable timeline based on everyone's availability. And we will have a couple of our board members participating too. So we'd love to hear what you think and probably watch for a survey to come out of that group at some point as well. And then that's my last slide, but I did have a couple other things just out of this conversation. I'm wondering if it might be helpful for folks if we convened just a call about HB 2002. And I don't know if people want to share what that looks like in their community, what their responses are. I know OHA is going to send you more information, and so I don't know if that's necessary, but just putting that out there that that's totally something we could do if you all are interested in talking about the impacts there and how to message that. So if you're interested, please put that in the chat, and that will give us a sense of if there are enough people that want to do that. And Kate will talk to you and or Emily about like if that's a joint thing or maybe OHA can't do something. I never know what your rules are. But that is an option. Okay, and then one last thing to add, which is the National School-Based Health Alliance is having state-based what they're calling GRIT awards, and GRIT stands for something, but I don't know what those words are. But in essence, it is awards. You can nominate people at this link that you feel like are really making, significant contributions to this field, and they can be anyone. They can be your reception, your provider. They can be a school administrator, a teacher, a community champion, like the communications person. It could be anybody. If you want to nominate people, please submit to there. And then the process, I believe, is they will get them to us. And then we will narrow down in some way. So That's a fun way to recognize your colleagues. They don't have to be present to get the award. And just, acknowledge all the awesome work that people do. And so with 3 minutes left, maybe we could look at that Jamboard and see all the awesome work that people did.
There's one question in the chat, Maureen, about where or how folks will know where the national meeting room will be for the national conference.
SBHA will label it somehow, and usually I think they put it in the agenda as well, but they usually give us the names of Oregon participants, and then we can email that out too. And for ordering the magnets or buttons, you can email this address, our admin@osbha.org.
Thanks, Maureen.
Yeah, thank you.
So we do have 2 minutes left. Kwong, I wonder if you want to pull up the Jamboard. I think there's just one page where folks put their achievements and wins for the year. Melanie, I can turn this over to you too.
Yeah, sure. And I just put the link in the chat. I know I've put it in there a bunch of times, but kind of hard to read, but there's so much great stuff here. So many great sticky notes about yak retreats, opening up new yaks, hiring lots of behavioral health staff. I love the one that says that they have the same providers for the entire year. I feel like that's totally a win. So congrats on that. Expansion of services, lots of great stuff. Telehealth, mobile. I encourage you to take a look. I know we're running out of time and there's some closing stuff, but please take a look and check out what's happening, and we'll try to include it as a PDF in the slides that we send out so that y'all can see the great work that's happening around the state by your peers. Nice job, everybody.
Love ending on a high note. And, as always, just want to recognize, even if it's not captured on the Jamboard, like you all have been doing so much. I think we heard so much from folks during this meeting about all the incredible work that's going on. It cannot be contained in a single meeting, all the amazing stuff that's happening. So thank you for all the work that you've been doing. As we mentioned, we'll be sending out the slides, any other supporting materials at the end in the next couple weeks. Stay tuned for more information about the fall coordinators meeting. We are hoping to have it tentatively in person. More information to come. We'd love to see your faces for the first time in 3 years, maybe more, 4 years. And yeah, I guess last slide, Kwong, happy almost summer break. I hope it's starting to feel like it where you are. I hope you get some rest this summer. Thank you for everything that you've been doing to support young people in your communities. Good luck with the rest of your school years and have a wonderful summer. Maybe last slide, Kwong. Here again is our contact information if you have any questions or anything you want to follow up with us on. But yeah, thank you for your time. Thanks for being here, and we will see you next year. Bye, everybody.
Bye.